Chapter 4, Lecture 2, Global Healthcare Comparison. In the previous lecture, you learned that the reimbursement and consumer cost sharing based on the risk management have a very important actually impact on production and consumption and delivering services. So according to health policy makers, cost sharing is required on the supply and our demand side of the market. So if you wanted to avoid overusing or abusing medical services, then we have to set up the cost sharing and reimbursement for fixed and variable payments, the way that people avoid overusing and abusing medical care. By setting up the right amount of reimbursement and cost sharing, we can actually we can reach to the our triple aim of improving the quality of care and decreasing the healthcare expenditure by basically that we can actually afford to cover everybody, full universal access for everybody. Now, suppose that you have you are very good in economics. You take this class very successfully, and you graduated with your Master of Public Health, and Congressional Budget Office hires you as a senior economist, and your boss is asking you to basically outline a proposal for national health insurance. So as part of your proposal, your boss is asking you to discuss about the benefit package. What should be included in this benefit package? Do you want it to include inpatient, outpatient, nursing home, dental, vision? What is the benefit package? And then the second question is the beneficiary. Who are the beneficiary? Do we have to include everybody, just the elderly, those are poor? So who are the beneficiaries? You have to determine that in your proposal. And the method of financing. So how do we have to basically cover that? Do we have to cover that by taxing the people, by mandatory basically taxing, compulsory taxing, or do we have to be a voluntary based on their premium by private insurance? So you have to determine method of financing should be federally financed by states, private. So the next one, the fourth actually question you have to answer is a delivery of service. So how do you want it to basically deliver that? Again, is this federally or private? So the physician should be hired by the government, or they have the complete freedom to produce and deliver their own services. How should be this delivery? So basically, everyone receive same medical benefits. Or we have to just have a specific amount of medical benefits in delivering in different amount and for different basically plans. So you have to basically be very clear in your model. And the last thing is the role of government in regulation. Who sets the rule? the rules and basically should be federally ruled or provincial or by states basically, um, and also so how much the private sector have the control over their like physicians, do they have authority to do their actually business, or should be completely physicians be hired by the government, like for example United Kingdom, and so these are the plan. Um, they should be very specific in your plan when you're hired by Congressional Budget Office. Now let's see step by step. So when you have a research proposal, what is the first step you have to do? Yes, that's right. The first step is that you are setting up your research and you are collecting the information about the main global healthcare models, because you wanted to compare and contrast different global healthcare models in terms of all these questions that your boss asks you: the benefit package, beneficiaries, and the method of financing, delivery, and role of government. So you actually set up a search, and then you collect the information about the different healthcare models in the world. And you find out that there are 5 main global healthcare models in terms of access. At least let's start from the access. Um, so the first model is the tax-funded model. So it's by compulsory, basically tax-funded model that is collected. They are collecting tax, and which is basically single-payer system. The famous one in this started by United Kingdom. National Health Services is a public contracting system. Means that basically you're dealing with the government. Government is hiring all the medical care producer, and then delivering the service to the people. So the second one is a single payer system also, but this is actually it is the national health insurance model. This is basically the Canadian healthcare system. So we talk about the differences between the United Kingdom and Canadian system. For Canadian system, um, everybody is basically covered by universal coverage by the government. You don't have a choice to buy out your insurance. In the United Kingdom, you have the choice. Um, and so there are some other differences. We talk about that. The third category you find, the third model, is the employment-based insurance model. The famous one is in Germany. So basically, most of the people are covered by their employers, and those people are poor or they are rich. They don't want. They can actually. The poor one are covered by government. The rich one, they can actually buy their own insurance. The fourth healthcare model is the private insurance model, which is actually the main one is in the United States. United States has the highest rate of private insurance, basically planners. And the last one, the out-of-pocket model, also mainly is in poor countries, and also in the United States. About 9% of people, they don't have insurance. They pay out of pocket when they need medical care, and so it's the out of pocket model is mainly in the United States and in the developing countries, poor countries. So I would suggest you to watch this video that is a summary of these 5 models at your own time, basically. Now, Let's go in detail and talk about these five main global healthcare models. The first one, we said that, okay, let's start with Canada. And the single payer system by Canadian ranks high for quality of care, but has long waiting time. So, so they have actually a problem with the waiting time, which is actually one of the characteristics of the quality of care. Now, the cost, if this is a Canadian system, it is actually called as a cost-effective combination of private and public funding. So each province finances its services through income tax services, tax which is received from federal funds, and so therefore basically there's no need for insurance. Although right now in Quebec, it's kind of Quebec is kind of exception, but in other provinces there is no insurance. Everybody is covered by the universal cover of single payer by government. There is no deductible, there is no co-payment. So when you go to the doctor practice is private, is a fee for service basically. Unlike Britain, United Kingdom, basically there is no possibility to buy out of system. So you have to have the health insurance from the government when you land into the in Canada. The first thing you get is the social security number, and then you get your health insurance card. So it's basically free for everybody. And then and you can just use that health insurance card for hospital, inpatient, outpatient, and everything. You can't basically pay out of your pocket to in Canada. There is no way. So the private health insurance is not permitted for basic hospital and medical services, but you can buy from your employer's insurance. You can have the like vision, dental, and all the extra additional insurance, the fancy one as well. But for the basic hospital and medical services, there is no way. And the only thing you can basically get from your workplace, the insurance, is the dental and vision and all the extra, fancy insurance one. Now, the second type we said that is a single payer system. The UK National Health Services is a public contracting system. It's based on the tax base. There's no cost sharing like Canada. There is no cost sharing, but there you have a choice to buy out of system. So 10% of UK people, they have private health insurance. Doctors work for National Health Services. So basically, all the providers are contracting. All the providers are public contracting. In Canada, in contrast, physicians, they have their own authority and they have full control of their own basically business, although their fee should be approved by the government. Now, the five main global healthcare model. Let's see. The third one is the employment-based insurance model. Is a non-profit which covers everybody in Germany. And Germany, France, and Japan. So those people, they have job. They are covered by their employers, and then their family are covered by employers. And those they don't have money, the governments cover them. The fourth category of the global healthcare model is the private insurance model. Is funding is based on the premium and is provided by private insurance companies, existing pure from basically in the United States alone. It only covers those who are insured basically. Um, the biggest percentage of this private insurance model is in the United States. Now, the last category, the fifth healthcare model, is the out-of-pocket model, which paid at point of use. You pay out of pocket. It is mainly used in the rural region of developing countries, and for American without insurance, about like 9% of American they don't have insurance and they pay out of pocket when they need medical care. So this number was like this percentage was 16% of American without insurance before the Affordable Care Act, and recently in 2016 reached to 9%. Again, let's talk a little bit more about Canadian healthcare system, which is a national health insurance. The Medicare for all single payer and universal coverage. So there's a difference between single payer and universal coverage, and you have to be careful. When we say that universal coverage means that everybody's covered, but a single payer means that one actually entity basically covers everybody. Government covers everybody. But in the United States, we have single payer for over 65 years old, but we don't have universal coverage. Now, the financing in Canada, the public funding covers 70% basically, and private 30%. So this private mostly covers the private insurance mostly covers the drugs, dental, and optometrics. So the public basically covers all the hospital and physician and basic medical care. So the income, basically the income taxes covers everything, and there is no deductible, there is no co-payment, no cost sharing. So first dollar coverage means that there is no co-payment, no deductible. So from the first dollar coverage, the insurance covers that. In the United States, some of the insurance, they have a deductible. You have to, basically, for example, 1,000 deductible means that you have to spend up to 1,000, and then after that, you are covered. Your coverage starts. Government provides 40% in direct cost sharing, and then so the private insurance through their job, but not permitted for basic hospital and medical services, covers the drugs and dental and optometrics. Now, the delivery, what care is provided to whom and by who? These are the questions you have to answer for Congressional Budget Office. The public funding in Canada, so it's a public funding, but private delivery, including the hospital, physician, nurses, technician, etc. So it's a so that's why basically the quality of care is high in some point, but so since there is no actually cost sharing, that's why the waiting list, the waiting time is very huge. So the people are overusing it. Everyone receives same medical benefits. So and we talk about that. What is the difference between the medical benefits in the United States when we are comparing with the Canada? They have an average medical benefit for everybody that covers everybody. United States has a higher technology, health technology, which basically covers those people they can afford and they have insurance. Regulation, who sets the rules and what rules do they set? The federal government set the rules, and provincial governments adjust based on their geographies and population needs. Now, the physician in Canada, nearly they have unlimited choices in treating patients. They have unlimited choices, but their fees should be set up by government. United Kingdom National Health Services is a public contracting model. It's a single payer government contract with various providers of healthcare services. It is funded by taxes and compulsory contributions. So the independent community-based family practitioners have limited physician choices, and the hospital trust, there is each district health authorities is responsible for assessing and prioritizing the healthcare services from public and private healthcare providers. Capitation, it is based on the capitation basis, so they avoid the fee-for-service reimbursement. They have a per diem, per person negotiated fee for service. And we talk about that, what is the difference between this negotiated fee for service or with the fee for service alone. So basically, one choice is that the physician is responsible for treating one patient, and based on that, covers the fee. For example, if the government says that this patient has a diabetes and you cover this, basically you treat that patient based on the diabetes, and then so there's no actually risk of overusing medical care from both sides, of producer or patients, because both of them, they wanted to treat fast. So that's a good actually financing model. Now, Germany is a socialized health insurance, has a socialized health insurance based on the government mandated financing by employers and employees. So it's a private, not-for-profit insurance companies. So it's based on so there is a sickness funds that, basically, if you get sick, you use that funds. It collects employers and employees' insurance premiums. So it's negotiate lump sum funds and negotiate fixed prices for various procedures with the local hospital. So negotiation always is helpful for cutting the price. In the United States, we don't have negotiation basically with the government, with the with the industry, or with the pharmaceutical companies, or for example with the hospitals. Negotiations are based on the diagnosed related group. This is the best actually reimbursement model, because the diagnosis related group is basically asking the doctor to treat a patient based on their related diagnosis. If the patient is suffering from high cholesterol or diabetes, then you have to basically, the physician will be paid based on treating this patient for that specific diagnosis. Now, there is no incentive to overuse the medical care. There is no incentive for the patient to go more than it's required to the physician, and there is no incentive for physician to ask the patient to come to more than it should be. So that's a very good model, financing model. In Germany, the rich and self-employed buy private insurance. So let's summarize the three basically countries based on their financing, delivery, and regulations. Remember, these are very important factors uh, to determine the healthcare financing system, healthcare model. Um, so in the United Kingdom, it's a tax funded model. Uh, Total populations are around 64.5 million people, and the population younger than 65 years are about like 80% of the population. So it's basically a kind of aging population in United Kingdom. The life expectancy is high, and the per capita health expenditure is around 4,000. Um, so their healthcare system name is called National Health Services. Um, the financing is by public, primarily funded with taxes. There are limited co-pays. Basically, is nothing, and then there are private employers, employer provided policies, and people they have a choice to buy out of system to have their own private insurance. The delivery is a universal coverage, and then the general practitioners they are contracted by the NHS. The outpatient specialists are NHS employees, and the hospital mostly public, and there are some also private. Now the regulations, the legislative bodies is a parliament, the Secretary of State for Health, and the Department of Health. The regulatory authority is the NHS England. Now, the United Kingdom ranked 21 in based on the VHEI that we talk about that later. Now, in Germany, as we said, it's the employment-based insurance model. The total population is about like 81 million people, and with 22% of the population younger than 65. The life expectancy is about 81 years, and healthcare expenditure per capita is about 5,500. The name of their healthcare system is statutory and private health insurance. So starting from the financing, is the statutory health insurance covered by taxes. So it's basically based on the percentage of the income, and there is a small copays, and then also there are private health insurance, which price based on the risk factors. And the delivery is the general practitioners and the specialists. They are based on the fee for services. The hospitals are state-owned, non-profit, private, and for-profit, actually private. And the regulation is the government mandates health insurance and allocate funds, but of course leaves the private group to provide and coordinate care. So it's basically the coordination is privately, and the third is a federal joint commission for regional providers association, and is a competing non-profit, non-geo health insurance funds. Germany's healthcare system from so many actually factors that we actually talk about that ranked 39 among 55 countries. Uh, then the next one is the Canadian healthcare system. It's a national health insurance model. The total population of the in millions is about like 35 million. Usually, remember that the Canadian population is 1/10 of the about 1/10 of American, and everything I wanted to compare. Usually, I look at this comparison of 1/10. About 15% of the populations are younger than 65, and the life expectancy is about 82 years, and per capita healthcare expenditure is about 5,000. The name of the healthcare system is Medicare. The financing is a single payer via provincial general tax revenue. The federal cost provides funds through the Canada Health Transfer. There is no co-pays for the public services, and 67% have private insurance. Remember, the private insurance is only for the dental, vision, and just extra medical care. Otherwise, you have no choice to use your private insurance for the general medical, basically, reasons such as hospital or a physician office. The delivery is a universal coverage organized by territory and provinces, but the providers are private. So basically, the physicians, they have full authority. So in Canada, the hospitals are a combination of public and private, but predominantly not for profit, and it is varies in different by province. So the regulation, the provinces, primary jurisdiction, ministry, they actually run their own, but in the national level, the Health Canada federal, the Public Health Agency of Canada, running the whole healthcare system. There are other agencies or non-GOs providing the oversights. Canada Health Act. In general, Canadian healthcare system ranked 16 out of 55 countries. Now, let's just explain in terms of triple aim, in terms of access, number of the primary care doctors per 1,000 people. Germany was the first. Germany has 4.1 physician doctors per 1,000 people, and then next we have France, and then next we have UK, and then US and Canada is the last one. That's why you see that Canada has a high waiting list for basically physicians and hospital. In terms of again access hospital beds per 1,000 people, Germany again is the best. Germany has 8.2 hospital beds per 1,000 people. Then comes France, and then US, and then UK, and Canada is the last. Again, that explains the waiting time in Canada. In terms of percentage of people without medical insurance, we have Canada ranks 0, then we have UK is 0, and France is 0.1%, and then Germany is 0.2%, and United States, it was in 2016 around 9% after Affordable Care Act. And then with repealing Affordable Care Act, that is going to increase to over 16%. Now, in triple aim, in terms of the healthcare expenditures, the U.S. spends more on healthcare than any other nations. So the cumulative differences between, for example, 1980 to 2010 is about like $15.5 trillion. As you can see in this graph, comparing the United States and Switzerland, United States is the most expensive, actually has the most expensive healthcare system with around $9,000 per capita, basically, per year. Now, we can actually use this money, $15.5 trillion, we can transfer our basically that money to 11.6 trillion federal debt into a 3.9 trillion surplus. We can basically pay off the debt and even have some surplus. We can send about 175 million students to a 4-year college. We can cover an area the size of the South Carolina with solar panels, and we can buy everybody in the world 4 iPad. Now, in terms of quality of care, healthcare related, let's use this healthcare related avoidable mortality per 100,000. Germany is the first, basically, in terms of avoidable mortality, and then comes the France, and then US and UK and Canada is the last. And then in terms of quality of care, when we are conducting a survey, public views of healthcare system, and we ask that, for example, needs to be completely rebuilt. As you can say, that needs with the red, United States. In the survey, most of the biggest percentage of the people they ask, they believe that it needs to be completely rebuilt, the healthcare system. In case of quality of care, what patients pay to see a doctor in Canada is free, in UK is free, France $25, of which most is reimbursed later. In Germany is between $5 to $11. In the United States it's about $30 to $200, depends on the type of insurance. If you have insurance, it's usually $30 when you go to the doctor. If you don't have your insurance, you don't have, or you have a bad insurance, then you have to pay $200. So in terms of triple aim, the performance of the United States system, the Bloomberg Healthcare Efficiency Index assesses life expectancy, healthcare spending per capita, and relative spending as a share of gross domestic product. And yes, out of 55 countries assessed in 2014, where do you think the United States rank? Yes, out of 55 countries assessed in 2014, the United States ranked 50 out of 55. So the U.S. Life expectancy was about 79 years, expenditure average about 9,000 per person, so about 17.1% of the GDP, basically which accounts for 17.1% of GDP. So the other countries, they have higher expenditure, or only 2 countries with the higher spending than US are Switzerland with about 10,000 per capita, and Norway again with about 9,500 per capita. But their average life expectancy was also about 4 years longer than United States. So maybe that's a reason for differences. So, in summary, the performance of the United States system in terms of access, we have uneven and on average low given no universal system of health insurance. There are several dimensions of access. The biggest one is cost. So the cost is the main important point, basically preventing the people from access to care, because if you don't have insurance in the United States, it's very costly. So the cost is the main major problem for accessing to the care. In terms of quality, on average, we have poor quality, structure, process, and outcomes. And in terms of cost, high level and high growth over time, um, and with no basically even quality of care. So then, which country system is the best if you wanted to actually make a decision? If you look at actually the dark blue here, the navy one, United Kingdom seems to have a higher quality of care compared to the other countries, although they are dealing with their financing these days. So now you have to basically sit down and write your model of the healthcare system for your boss, for Congressional Budget Office.